First of all, let me thank everyone for inviting me, involving me in this study session. As a junior, as a beginner, the most important skill to begin in histopathology is grossing. And I learned very early on in practice that when we make mistakes in grossing, we end up giving out a bad report. I will be discussing grossing techniques for GI specimens, bigger ones. This is a quote from Ludman saying that macroscopic assessment of a colorectal resection specimen is of utmost importance. No amount of clever microscopy can redeem a poorly dissected specimen. So my sentiments exactly. So it is very easy to dissect a hemicolectomy or a complete colectomy. You just take two margins, proximal, distal, you take the size of the tumor, you find out the depth of the tumor, and lymph node dissection, and that's it. But some of the specimens, some of the colectomies that we get are specific, they are unique in the sense that there are some concepts which one must know before you begin grossing these specimens, because that has to reflect in the reporting. So first of all, why is the grossing important? The biggest question is, what does the surgeon want from you? The answer is obviously the classification, which demands what is the tumor grade, tumor stage, and the lymph node and margin status. So without going into much of these specifics, I will just show you what I mean by good grossing. So types of colectomy specimens that we generally encounter in practice are listed here. But the most complicated ones are the low anterior resection or the abdominoperineal resection, which and nowadays with total mesorectal excision. Nowadays there is no concept for partial mesorectal excision. So APR, LAR specimens, they are generally a treatment for rectal carcinomas, upper one-third, carcinomas in the upper one-third or two-thirds, they generally prefer a low anterior resection. It is a better surgery as compared to abdominoperineal resection because the sphincter function is retained in most of the LARs. Abdominoperineal resection, on the other hand, is generally preferred when the tumor has already affected the sphincter function. This slide highlights the difference between grossing an LAR or an abdominoperineal resection. It is because the peritoneal reflections are different for different parts of the colon, especially the rectum. So I want everybody to understand that the last line where rectum, the upper third is covered by peritoneum on the anterior and lateral surfaces. So the upper one third, middle one third, and the lower one third. So a schematic representation of which is here. The blue highlight is for the peritoneum, and the rest is the non-peritonealized surface. So when we take cross sections, the corresponding cross section will show a different picture. On the upper one third is mostly covered by the serosa. Only a part of the posterior surface is not peritonealized. In the middle one third, sorry, almost half is peritonealized, half is not. That is, the posterior half is not, and the lower one third is completely non-peritonealized. So this is important because the non-peritonealized surface is the one which we refer to as the circumferential radial margin. When do we call something as a margin? Anything that has been bluntly or sharply dissected qualifies as a margin. So this non-peritonealized surface is a margin for the LAR and APR resections. That is why it is important to mark it. This is another, this is the same depiction on a specimen. So the dotted line is the demarcation between the upper serosal surface and the lower non-serosal surface. The same thing on the right side, the posterior surface, it is uh, almost not peritonealized from above downwards, almost to the 2/3 and the upper 2/3 and the lower 1/3. So the same thing. So this is a specimen that how do we identify this margin? So this is a specimen that we have grossed over here, and one can understand that this is the shiny serosal surface. This is the demarcation, and the non-peritonealized surface on the anterior side and the posterior side has been inked so that we can identify it on microscopy. This is an APR specimen, so I'll just show what its proximal and distal margins look like. So this is the distally, there is anal margin. So this is not a margin at all. And this is the tumor. It was a circumferential tumor of the involving the rectum and the dilated rectosigmoid pouch above, proximally. So in this case, the proximal margin and the proximal margin and the circumferential margin is what we are interested in. Again, to stress, the radial margin status is the single most important factor for predicting the risk of local recurrence, distant metastasis, and mortality in patients with rectal cancer. There is something new that CAP protocol, according to the CAP protocol, one has also got to comment on the type of mesorectal excision that has been performed. The type as in the gross assessment, whether it is complete, whether it is incomplete, or whether it is in between, so intermediate. What does mesorectal excision actually look like? So this is the schematic representation that I have made. Mesorectum is actually the non-visceral surface. So this is the visceral peritoneum, and this is the non-peritonealized area. The perirectal fat, perirectal connective tissue is excised in order to include most of the involved lymphatics, so that one gets a surgical clearance on this side. So again, it's a margin. This I have taken from the CAP protocol, where the assessment has to be done on gross, and one can confirm it on microscopy. Mota, what the incomplete, nearly complete, and complete means here is whether the muscularis propria has been exposed or not. If one can see a muscularis propria exposed, that means it's an incomplete mesorectal excision. If one cannot see, if the donuts that we cut are circumferential margin, it appears smooth, and the muscularis propria is covered from all sides regularly, that means it's a complete excision. And anything in between, mostly a 5 millimeter margin is considered enough. So anything in between is nearly complete or intermediate. So going ahead, after one has inked the non-peritonealized area and a donuts serial sections or donuts have been taken in this way, the tumor size is assessed. The size, the depth is important, because depth will depict whether the radial margin is involved or not. So anything below 1 millimeter is fine. So a 1 millimeter distance between the radial margin and the tumor has to be there grossly to say that the margin is free. Of course, one has to confirm it on microscopy. So what sections are we supposed to take? So at least 3 blocks with the tumor and the margin, the circumferential radial margin, 2 blocks of the tumor from the luminal aspect, the proximal and distal margins, lymph nodes. Lymph nodes, especially the mesorectal lymph nodes, there is a note about lymph nodes. If a lymph node is completely involved by tumor, one cannot identify any lymphocytic follicles in the lymph node, then it qualifies as a tumor satellite nodule, and it will be according to the staging, it will come as N1C. It will not be counted, it will be counted in the regional lymph nodes only. And since we are on lymph nodes, in colorectal specimens, anything that is external iliac and common iliac lymph nodes are counted as metastasis. Anything else in the region are regional lymph nodes. So we were on sections. So after the tumor sections, margins, tumor sections, then the lymph nodes, and then one has to not forget the rest of the colon. So if there is there any polyp, mass, stricture, growth in the rest of the colon. And yeah, that is all. So number of lymph nodes, it is imperative, it is important to gross at least 12 lymph nodes. In a colectomy specimen, anything below 12 lymph nodes, it decreases the chance of detecting metastasis marginally. So 12 lymph nodes is the minimum amount that one has to dissect. And not only the regional lymph nodes, anything, all the mesentery that comes attached to the peritonealized area also has to be dissected. This is the depiction of the T staging, so that one understands why it is important to note the depth of the tumor. And depth not only on microscopy, of course, one has to see whether it is muscularis is involved or not. On gross, one has to make a note. How deep do you think the tumor has reached? Has it reached the muscularis? Has it reached the adventitia? Has it reached the subserosa? Or has it crossed from the serosa, and is it affecting, has it adhered itself to an organ? Because that is what the T staging gets affected by that. So T1 is the submucosal spread. The tumor has reached the submucosa, it has crossed the muscularis mucosae and gone into submucosa. T2 is involvement of the muscularis propria. T3 is the involvement of subserosa. And T4 is the involvement of the visceral peritoneum, and probable, if at all, any invasion into the adjacent organs. Now, adjacent or not the ileum or the adjacent large intestinal segment. Okay, so there is another thing that one has to remember here. This serosa, by serosa we mean visceral peritoneum. It does not mean the non-circumferential margin. So if the non-circumferential margin is involved, but there is no invasion in the adjacent organs, the staging will be, it will be T3. So if you see here, this is the left, this is this diagram on the left side. It shows that the visceral peritoneum involved, this is T4. But in cases of non-peritonealized area involvement, that means it is a T3 involving, but resection. R2 is the resection staging in according to CAP protocol. So, but resection is the surgical clearance is not proper, and that a margin is involved. So, I hope the concepts are the same for low anterior resection. One has to, the trick is to identify the peritonealized and the non-peritonealized area and do a proper lymph node dissection. So going ahead, another specimen which I feel needs to be addressed is the Whipple's pancreaticoduodenectomy. A Whipple's procedure generally for any ampullary or for pancreatic tumors, it can be a complete, it can be a partial pancreaticoduodenectomy with or without a stomach sleeve. So there are types of, so any Whipple's will always involve these structures. So there's a second part of the duodenum. There's the ampulla opening, ampulla of Vater, the CBD, cystic duct, and gallbladder. So this is the basic anatomy of the Whipple's. Why is it complicated? Why is the Whipple's complicated? Because the pancreatic, this is the partial pancreatectomy, where this is the cut margin of the pancreas, and there are pancreatic surfaces which we have to address. So now again, margin. So here what qualifies as the margin is the pancreatic cut margin, the proximal duodenal margin, the distal duodenal margin, and the surfaces of pancreas, because the surfaces of pancreas have been bluntly dissected from the vessels around it. So the rule of hand, if you cannot identify the pancreatic surfaces, please don't assume anything. Call the surgeon, ask him to show you the SMB groove or the SMA groove and the retroperitoneal surface. Though it is easy to identify them, how do you identify? Anterior surface is generally smooth, covered by serosa. The posterior or the retroperitoneal surface is rough and bluntly dissected. It will show you, it will show connective tissue tags attached to it. And the SMV and the SMA surface, this one is generally lateral to the cut margin, the neck cut margin, and it will show you, actually it will show you a groove which is just adjacent to the CBD opening. So as you can see, you have to, there are 4 surfaces which you need to identify and ink them. So every hospital has a protocol for inking. Mostly the anterior surface is, I mean, you can give any codes. So we do anterior surface as red, retroperitoneal surface is black, the SMB and SMA surface blue and green. So there is another margin which has been described in CAP according to CAP protocols, which is the uncinate margin. So again, because it is blunt, there has been blunt dissection on its posterior lateral surface, it qualifies as a margin. So you can involve the uncinate margin depending on where the tumor is. You can either take a shave margin or a direct cut margin also. So there are 2 schools of thought as far as Whipple's pancreatectomy dissection is concerned. Some people prefer an axial dissection like this. So this dissection gives a good orientation orientation as in of the tumor with the surrounding structures like the duodenum, the CBD, the pancreatic duct. So one can visualize everything uh, at uh, at serial sections. But sometimes it becomes difficult to identify or orient the specimen, and it is easier to cut the CBD and the pancreatic duct longitudinally. So you can identify whether the tumor is small tumors, polyps, or the IPMNs, those kind. But mostly, I believe this is a good way to go about. I will show you some of. So I have not completely separated the pancreatic, the duodenum here. So this is the second part of the duodenum. Okay, you can identify this is the duodenum. This is the papilla, ampulla of Vater, sorry. Okay, the duodenal, other duodenal sleeve. This is the anterior surface of pancreas. This is the SMV and the SMA groove. And there's this black retroperitoneal surface. So this is the tumor. This is the ampulla which has been dilated, and there is a tumor sitting inside it. So serial sectioning, as seen here, when you orient a specimen, you can understand what is the extent of the tumor. Is it involving only the ampulla, or also is it going into the proximal CBD? Is it involving the pancreatic duct? Is it going into the duodenum? So I believe this is a good way to go about it. Some more photographs I'll show you. Again, the same thing. So here you can see this is the dilated the ampulla had dilated so much, and this is the proximal part of CBD which is not involved. So this is a single cross section. So this is the ampulla showing a papillary fibril tumor over here. This is the papilla and a duodenum. So this is the duodenal sleeve. This is the pancreas around it. There's one lymph node over here. So this turned out to be an intraampullary papillary neoplasm. It is quite big, 2.7 centimeter tumor. It's a pre-invasive neoplasm, although. So minimum sections that one should take in a pancreaticoduodenectomy are the proximal duodenal, distal duodenal, or distal jejunal margin, whatever comes. A CBD cut margin. If you have got a frozen margin, then that suffices. A pancreatic neck margin. A shear margin is okay if the tumor is quite far away, but if it is quite near, then you have to go and take a perpendicular margin. Uncinate margin, as we have already discussed. After that, tumor with adjacent margins, if it is quite close by. Tumor along with the adjacent structures, the duodenum, ampulla, pancreas, CBD. So in this case, the ampullary tumor had gone and involved the papilla as well as the ampulla. So that is what, in order to understand how and where, because the entities are very close. The ampullary adenoma, a duodenal adenoma can also look like this, but had I not grossed it and understood that the ampulla has dilated so much, it would have looked like a duodenal adenoma. So the localization needs a good gross. Superior mesenteric vein goes along with just alongside the CBD. So sometimes the surgeon will dissect it also. So one should make sure that it is sampled. Lymph nodes, again, lymph nodes, you need not generally, if you can identify the type of the place, the localization of the lymph nodes, then one should take it, and it is easier to identify because the all the connective tissue around the anterior pancreaticoduodenal, posterior, the cystic duct, pericholedochal, superior pancreatic, inferior pancreatic. So this is identifiable and doable, but it does not hold any such, if you are not able to do it, it will not affect the staging as such. But you should try to do it. Okay, so lymph nodes, again, 12 is the minimum number of lymph nodes. A school of thought says that all peripancreatic fat and connective tissue should be submitted, just so that you don't miss any of the smaller lymph nodes, and if satellite nodules are there, if any. Adjacent duodenum, CBD, and pancreas should also be submitted. So I guess all my all the grossing tips that I have discussed today, I have learned from mostly the CAP protocols and the Royal College of Pathology protocols over a period of time, and this is my source of reference. Thank you everybody for patiently listening to me. Thank you everybody.